We're live, sir.
Okay, thanks, Shamshul, and welcome everybody to this today's evening webinar. This is a series of talks, really primarily focused on PNB and postgraduate students. Today, the talk is going to be on revision ACL reconstruction, and the speaker is going to be Dr. Arvind Gupta from RSHMRI Hospital, Patna. I think in the last decade or so, there are two things have happened. One is that there's definitely an increasing number of ACL injuries, and although a lot of them used to be managed conservatively earlier, almost all of them are being operated on today. And although it's a very successful operation, we do see failures, and when they fail, the solutions are not always easy, and you have to know how to assess them and decide on what you need to do in those particular cases. So I think Arvind has a lot of experience in this and will be the best person to talk to us about this today. Arvind.
Thank you, sir. Thank you for invitation. So today I'll discuss about the revision ACL. What are the planning thing and what are the technique? So this was the young guy operated just 6 months earlier, presented to us with this much of instability almost 6 months after ACL reconstruction. So this patient was doing himself this pivoting and anterior translation of the tibia. So failure rate for ACL reconstruction in literature vary from almost 1% to 30%, but very common is around 6 to 7% after primary ACL reconstruction. So what constitutes failure after ACL reconstruction? Well, we'll see it's failure. So when there is recurrent tear, injury around the knee, then there is a stiffness after ACL reconstruction or arthrofibrosis, or there is any pain while walking, or there is some increasing arthritis component. We can see the limb is painful with this guy. Then there is persistent instability after ACL reconstruction. And there is extensor mechanism dysfunction also. There is a lot of quadriceps atrophy. Patient is unable to fully extend the knee also. So all these constitute the failure of ACL. And why this fails? What are the reasons behind this? So first is the trauma. Like this patient having very good healthy graft was there, and orientation was also good, but because of the trauma, the reconstructed ACL get failed. The next is the technique about the making the tunnel in the femur as well as in the tibia. So this tunnel should be horizontal like this. When this tunnel is vertical in the femur, graft will be vertical. So this ACL will provide only anterior posterior stability. But when you will talk about the rotational stability, this graft will not provide that because this is vertical only. So it should be the horizontal. Horizontal graft will provide both anterior posterior stability as well as rotational stability. So this was about the femur in the coronal plane as well as in the sagittal plane. If graft is too posterior, then this will be tight in extension, and then this graft is too anterior in the sagittal plane over the femur, then this will be tight in flexion. Hello. Then the next is tunnel over the tibia also, and the graft is too anterior over the tibia, then this will impinge over the notch. And similarly, if too posterior, then this will impinge over the PCL that is coming from posterior to anterior. So after technique, the next common thing is the biology. Like this patient, again, very well-oriented graft with posterior tunnel, but it's never healed to the femoral side. You can see this graft, none of the part of graft has healed to the femoral side. So biology is another important factor. We have to look. The graft has to heal with both tibia and the femur after reconstruction of ACL. Then there is lot of structure that provides secondary stability to ACL, like meniscus, like collateral ligament, and recently discussed ligament is the anterolateral ligament. That is another very this significant ligament that provide secondary stability to ACL, particularly the rotational instability. Like this patient, if you see, this is athlete patient playing football with grade 3 anterior dot test positive. And about the pivot, you can see also this patient is having grade 3 pivot shift also positive. So, and if you see the MRI of this patient, you can see the anterolateral ligament that is under the IT band and just before the lateral collateral. This is the area where it should be attached in the axial section. This is the anterolateral ligament should attach over the tibia. This was done. So this type of patient should be treated with ACL along with anterolateral ligament at the same time, because of grade 3 pivot along with high demand patient. This patient was playing football. So both the reconstruction should be done in such type of patient. The next factor is the gender. Female athlete is having high risk for ACL, revision chances. At the same time, if patient is having generalized laxity, that should be also evaluated when we are examining the patient for the knee for ACL tear. So generalized laxity should also be looked. And next is the malalignment, whether there is varus malalignment or valgus malalignment. Like this 44-year male having ACL tear, you can see along with the medial meniscus tear, and at the same time there is medial compartment osteoarthritis with varus malalignment. You can see there is varus malalignment was there. So this patient was treated with tibial osteotomy along with the ACL reconstruction at the same time to prevent the ACL failure. So from the evaluation point of view, this should start with the history, and we should ask for whether this ACL reconstruction failed before 6 months or 12 months. Because literature says if failure is because of after very long time, then this is because of traumatic origin, or if because of very short time within 6 months, then it is because of biological failure. There is problem with the healing. And very long time ACL is going on, then it's failed, then definitely it's the traumatic origin. And also there is, if ACL failed and the reconstruction time is very long, then the outcome of such type of patient is not very good. Then next is the rehabilitation issue, whether rehabilitation was fast during rehabilitation after ACL reconstruction, and also whether there is recurrent giving away because of non-traumatic or because of trauma. So when we are asking about the history, then careful differentiation should be done, whether it's instability, whether it's pain or swelling. Because pain or swelling may be because of many factors, but the instability should be there for when we are going for a revision ACL reconstruction. And the next is the physical examination. And this examination should be done for each and every part of the knee, for ACL, PCL, lateral collateral, anterolateral, posterolateral structure. At the same time, the contralateral knee should be examined. This is very important because we have to compare the affected limb from the normal contralateral limb. Any laxity of 1 to 2 millimeter is normal, and 3 to 5 millimeter of laxity with firm in point also taken as normal. If any confusion, we can take the help of instrument. There is a lot of instrument is there so that objectively laxity can be measured. And recent literature says any instability on the medial side after ACL reconstruction, the chances for ACL failure will be high. Like this patient, 18-year male, presented to me with recurrent instability, and he has surgery in ACL reconstruction in June 2000, January 2019, and instability or persisting, and again in January 2020, again he has LCL reconstruction. And you can see the MRI of same patient after reconstruction of ACL. Definitely ACL is not working there, but his LCL was normal, MRI was. But again, LCL reconstruction was done, and this was done at very Apex Institute. But LCL reconstruction was done in spite of MRI was showing this much of figure that MRI is says the LCL is fine. So what was the confusing point? So this was the after ACL reconstruction, immediate, and this is after 1 year of that. You can see the tunnel for LCL is there. ACL is there, though it's a little bit of vertical. But again, LCL is not very anatomical. It was reconstructed there. So what was the problem? Why MRI says LCL was fine and reconstruction of LCL was done in this case? This is the recent clinical examination of this patient. You can see grade 3 pivot is there. At the same time, grade 3 anterior door test is also positive in this patient. You can see the anterior door test is also positive. So even after LCL reconstruction, ACL is not working. Stability to this patient is not there at all. You can see the incision for the ACL is there and LCL is there. So on thorough examination, it was fine. This patient is having generalized laxity of ligament is there. So on comparing with the opposite side, that patient was having little bit of laxity of the lateral collateral ligament on opposite side also. So in spite of being MRI was normal. So you can see the report of this patient, the medial collateral and lateral collateral are normal, but there is graft ACL that was reconstructed having tear. In spite of that, the reconstruction of lateral collateral was done because the opposite limb was not examined. And that limb was showing lateral laxity because this patient is having generalized laxity of the ligament. So comparing with opposite limb is very important whenever there is planning for revision ACL reconstruction. Next is the imaging. This should be a start with the X-ray, and X-ray should start with both the limb. It's not should be the affected limb only, both the limb AP view and lateral view. And in AP view, we can see the tunnel, whether it's vertical or not, any tunnel dilatation or not. At the same time on sagittal view, whether it's anterior, posterior, or anatomical. And recently discussed about the revision ACL is the slope of the tibia. So this slope of the tibia, this hypothesis is that if there is excessive slope of the tibia will move anteriorly and femur will move posteriorly. So there will be a stress over the ACL and chances of failure will be high. So recently lot of literature about how to calculate the posterior tibial slope. And this recent literature in 2018 says if any slope 12 degree or more than 12 degree is a risk factor for failure of ACL reconstruction. So this thing should also be keep in mind. So next is the long leg film also. This will say about any varus malalignment or valgus malalignment at the same time. The next is the CT scan. And CT scan in sagittal cut, we can see whether the femoral tunnel is anatomic or not. It should be in between 1/4 or 3/4 junction by method of Bernard. And at the same time, we can look for the dilatation of tunnel. That will be exactly measure how much is the diameter of tunnel. So we can plan whether it should be done in 1 stage or 2 stage. This should be evaluated both in the sagittal, coronal, and the axial view also. And also we can calculate the future tunnel. Like this patient was operated having very vertical tunnel of the femur. You can see the tunnel is there, and the future tunnel of this patient is somewhere here. So this tunnel will not going to interfere with the previous tunnel. So this can be projected on CT scan also. This can be done in both sagittal plane, axial plane also. The next imaging thing is the MRI that explain about the graft status, articular cartilage, and the meniscus. Because those who having failed ACL, only 10% will have normal knee, and almost 60% will both having some type of condyle lesion as well as the meniscal lesion at the same time if ACL is failed. Like this patient, 38-year male, presented to us after 5 years of ACL reconstruction. So we can see the tunnel is anterior and little bit vertical also. So about the how we can calculate whether this vertical tunnel or not. So this was published in 2011, American Journal of Sports Medicine, and anything this angle is less than 33 degrees, then this tunnel will be called as the vertical tunnel. So this should be somewhere here, and this is too vertical. Angle is hardly 20 degrees, so this is vertical. At the same time, on sagittal view, if this angle, tibial angle and the graft angle is more than 55 degree, then again this will called as the vertical tunnel. So this in this patient, the tunnel was vertical and this graft was failed. So this long leg film was taken. There was no varus valgus malalignment. MRI was taken that says there is the medial meniscus tear along with the graft failure. This was the coronal section, and this was the clinical examination of this patient. So you can see again there is grade 3 anterior dot test positive. And also about the pivot, you can see this pivoting is very easy going on. So this patient was having anterior door as well as grade 3 pivot test positive. No varus valgus test was positive. And intra the graft was failed, and also there was medial meniscus injury was there. So ACL reconstruction was done. That was augmented with the fiber tape. Recently in we have another thing to augment ACL whenever there is suspicious of too much of laxity. And also the plan for reconstruction of anterolateral ligament was done because of grade 3 pivot shift test in this case. So this anterolateral ligament is in between the Goddy's tubercle and the fibular head, almost one centimeter below the joint line and just proximal to the lateral epicondyle. So semi-T for the ACL and the gracilis was used for the anterolateral ligament. And this is the post-op ACL. You can see now the tunnel is more horizontal, more anatomical, both on the tibia and the femoral side. This is horizontal tunnel is there. And this is after almost 14-15 months after this follow-up period. You can see the ACL is nice and tight. There is hardly 2 to 3 millimeter of laxity. At the same time, the pivot shift test was negative. And also this is the clinical picture after 14 months. So patient is doing almost all the work, but still he needs to do some exercises to participate in a sports activity. So what are the surgical considerations should be taken care when you are planning for the revision ACL reconstruction? That should be staging, whether it should be single stage or 2 stage, which graft we should select, whether hardware should be removed or not, previous hardware, the bone tunnel placement, graft fixation, what are the method and rehabilitation. So final consensus about this staging. If any tunnel dilatation less than 14 millimeter, we can go for 1 stage. And if the tunnel is anatomic, both on the tibia and the femur, then we can go for single stage. And any tunnel dilatation more than 14 millimeter, we should go for the 2-stage surgery. And the tunnel is partially anatomic. It means if we create the anatomical tunnel, then this will going to coincide with the previous tunnel. So again, even if less than 12 millimeter, the single stage is little bit confusing. So we can go for 2 stages directly. And when it is non-anatomic and less than 12 mm single stage, dilatation is more than 14 millimeter, again confusing whether it should go for single stage or 2 stage. The literature says even less than 10% of the revision ACL required two-stage surgery only. Rest 90% of the failed ACL reconstruction get managed with single stage. So when there is too much of tunnel dilatation is there, we remove the screw, fill the tunnel with the graft. Then when graft get healed, then we proceed for the two-stage. And the graft in our scenario, we should take for the iliac crest. And this OATS instrument is very good instrument, so that exact diameter graft can be harvested and that can be placed into the tunnel. And that can be placed directly with the help of impactor, or we can make a drill bead pin in the graft, and then with the cannulator impactor, we can impact the graft into the tunnel, both in the femur and the tibia. Another condition where we should do in a staging, when there is a stiffness of the knee. So first mobilize the knee, and then we go for the revision reconstruction. And also if there is limb malalignment is there, then also we can plan in two-stage. About the graft, there is a lot of graft available here from the same limb or contralateral limb. So once soft tissue graft is failed, then we have bone patellar tendon bone graft. And nowadays there is a lot of discussion about the quadriceps tendon graft is also there. And we, in our scenario, a lot of peroneal longus graft is also getting used for revision ACL reconstruction. So about the hardware removal, it should be removed only when it is necessary. Don't create the bony defect by removing the non-anatomically placed screw there. So you can see there was a screw was there that was not touched, and the anatomical reconstruction was done with another implant. And whenever you have to remove the implant, you should have basket of instrument, so that there should be no any struggle for the removal. At the same time, you can take the help of C-arm. Like this patient, this has failed ACL reconstruction. Tibial tunnel was anatomic. There was no problem with that. So same tunnel was used. This was after removal the screw. And this after remove all the soft tissue was removed by further reaming, so that the cancellous bed should be available for the graft. And this is a final ACL reconstruction. On the femur, you can see the newer tunnel was created because this was non-anatomical. The tibial tunnel was anatomical, the same tunnel was used, but was a larger diameter. Similarly, when we are removing the femur, whenever there is any graft or a screw remnant, that should be removed before placing the graft. So the last about the revision, the next, this is the patient, the engineer from the Bangalore, presented to me after multiple surgery around the knee in 2015. And his story started with February 2019 when he sustained bicondylar tibia fracture. That bicondylar plating was done, but from very beginning patient was having instability at the time of walking. This is almost after 1 year, but still he has instability. So this patient was diagnosed that time ACL tear along with bicondylar. So removal of the plate and the ACL reconstruction was done with the help of bone patellar bone tendon bone graft. Bone patellar bone tendon is still very common graft in the south, particularly the Bangalore and Chennai part. So that reconstruction was done, ACL. But and at the same time, osteotomy was done after 6 weeks only. So patient was planned for ACL reconstruction and osteotomy in second stage. But even after osteotomy and ACL reconstruction, patient was having instability in the knee. So after that, almost after 6 months of that, the again revision ACL reconstruction was done by taking bone patella from the opposite side, and the posterolateral corner reconstruction was done. You can see the near this broken, this guide wire is there at the screw. So re-revision ACL with the posterolateral corner reconstruction. You can see the posterolateral corner reconstruction part over the femur is totally non-anatomic. At the same time, you can see the dilated tunnel is there. So this is the picture almost after 2.5 years of the primary injury. Patient is still having difficulty in walking. The femur is subluxated a little bit that side and tibia on that side, and this much of hardware all around the knee. So patient was planned for re-revision ACL, the second time ACL revision along with the revision of the posterolateral corner. CT was done. You can see the femoral post was almost non-anatomic, and it should be somewhere here. At the same time, you can see the 2 screw in the femur. So this is completely non-anatomic, and this you can see here also the dilated the tunnel over the femur. So the graft, since both the bone patellar tendon and one hamstring was used for posterolateral corner. So in this case, the bilateral peroneus longus was used, one for ACL and another for posterolateral corner reconstruction. So peroneus longus tendon is having one advantage: it's for a very bulky graft. Almost, if you do quadruple of that, so this will be almost 9 to 10 millimeter of diameter. So the ACL revision reconstruction was done. You can see the button there, so it's more horizontal, and also the posterolateral corner. This post was more anatomic in this part. This is for the posterolateral corner fixation along with the screw. This staple was used, and also the post was used along with the screw over the tibia. So double fixation for the ACL and double fixation for the posterolateral corner. Usually TBI is taken as the weak link about the fixation of the graft. So double fixation was used, and also there was a lot of osteoporosis and multiple tunnel was there all around the tibia. So double fixation was used both for the tibia and the femur. This was almost after the 6 months. So you can see the now almost the tibia and femur relation is getting better because of posterolateral corner part is fine. You can see the anatomic ACL tunnel is there, and patient has started doing all his work. So after some time there was problem with the screw, so removal of a screw was done. And this is almost after 6 months of this, 6 years, 5.5 years of this re-revision ACL reconstruction, and this posterolateral corner revision. And patient is doing almost a sports activity also and all his work. So about the rehabilitation, it should be slow and steady. Patient may take almost a year or more than that to get normal to his work, but it should be rehabilitation should be slow in case of revision ACL reconstruction. Thank you.
Okay, thanks, Arvind. I think we'll go on to the questions. Anyone?
Sir, good evening, sir. Suppose one patient after ACL injury at other center come to us after 4 or 5 months. Then how to suspect this ACL reconstruction is going to fail if position of tunnel is anatomical, sir?
Can you repeat your question, Gautam?
सर मान लीजिए कहीं दूसरी जगह से ACL करा के आपके पास 5 महीने 6 महीने के अंदर आता है पेशेंट और टनल का पोजीशन ऑन एक्सरे एनाटॉमिकल है, तो कैसे सस्पेक्ट करेंगे कि इट माइट फेल?
So what's your clinical examination?
Clinical examination, sir, suppose patient had mild pain only.
That's clinical examination or symptoms?
It's symptoms, sir.
What is the clinical examination? Movement, stability, Latchman's, anterior draw.
Okay, sir. Suppose anterior door is grade 1 positive and Lachman is negative, sir.
Doesn't happen that way.
This is hypothetical, sir. Hypothetical situation. मैं ये पूछना चाह रहा हूँ, sir, actually कि मतलब कैसे हम suspect करेंगे कि ये ACL fail कर सकता है?
So the first thing is you have to examine the patient to see if it is working or not.
Yes, sir.
Look at X-rays, huh?
Okay, sir.
So many a time, grade 1 laxity, anterior door laxity is very common after ACL reconstruction. If you are using a soft tissue graft, if you are not using BPTP or quadriceps bone tendon graft, then the chances of laxity around 5 millimeter is very common with soft tissue. So
Okay.
if patient is having pain only, but there is no instability, as we have discussed previously also. So instability is the hallmark for failed ACL, history-wise. And clinically also, if in comparison to opposite side, if in point is firm, even after
Lost you. Okay, so essentially your clinical examination will tell you if the knee is stable or not, okay?
Yes, sir.
You need to look at range of motion to look for stiffness. You need to make sure there's no inflammation, etc., suggestive of low-grade infection or anything like that.
Yes,
And
sir.
if it is just slight instability at that stage, which is within what we would consider physiological limits, we would advise physiotherapy exercises and continue, and you should not expect it to fail. If it's going to fail, you will start seeing instability, okay? I mean,
Okay.
Latchman starts getting positive and the endpoint is not firm, then you have to start suspecting that the ligament reconstruction either is not adequate or it's loosening. I mean, there's some stretching out which is beyond what is normally expected.
Sir.
So why do you need to tension your grafts, especially with the hamstrings and things like that?
Yeah. So tensioning device is also there. So we can tension the graft when you are making tunnel and other part. And if you are not using that, then we can tension the graft after fixing the graft over the femur and do at least 10 cycle of full extension to full flexion. So this much of load will tension the graft.
And sir, in case there is a sorry.
Yes, sir, carry on.
Sir, if the previous tunnel is anatomical, but there is a tunnel widening.
Yes.
In that case, what would be, sir?
So tunnel widening may be present there, but patient may be stable. There is no nothing like that. If tunnel is widened, then this knee is going to be unstable all the time. So tunnel widening may be there. That may be because of problem with when there is disparity between the tunnel diameter and the graft diameter. That is the first case. And tunnel diameter is more, and you are using the less diameter graft. Or there is, if you are using different type of fixation method, like suspensory fixation method will have higher chances of dilatation of the tunnel in comparison to aperture type of fixation.
Okay, sir, in that case, what is method of fixation in revision, sir?
If you are planning for revision ACL reconstruction in case of dilated tunnel, so look whether it's more than 14 millimeter or less than 14 millimeter. If it is less than 14 millimeter, then you can go for the same time single stage revision ACL reconstruction with bony plug. You can take the bone plug that heals very good with the bone. But if you are
in same tunnel, sir.
Yes, if it is anatomic.
Yes,
if
sir.
It's
yes,
non-anatomic, then there is no problem with that.
Yes.
And if you are using soft tissue graft, then you should have at least the same diameter. Suppose it's 10 or 11 millimeter of diameter of like our revision, it was almost 10 millimeter of diameter. So that much of soft tissue graft you have to make, either with quadruple, semi-T and gracilis. Adding gracilis same time will make 10 millimeter of diameter.
Okay, sir. Thank you.
So there was a question from Rajiv asking what is Cyclops lesion and how graft heals.
So Cyclops lesion, initially there was a lot of BPTP was used from very early time of when the time of ACL reconstruction. So this Cyclops is a soft tissue mass usually grown up in front of your ACL reconstructed. And that usually prevent the full extension of the knee joint. That can be very well diagnosed with MRI. when there is problem with the knee extension, and MRI says there is tissue in front of the ACL, that is called as cyclops lesion. And usually orthoscopic removal of cyclops will take part of that. But many a times when you are using soft tissue graft, then this cyclops may form because of some type of low-grade infection that recently we have treated one of the patient. That patient was having low grade of infection. There was a stiffness. There was full extension problem was there. So that patient was having cyclops because of this low grade infection also.
So, most common location of cyclops lesion, sir?
Just anterior to your ACL tunnel at the tibia.
So
Okay.
why is it called cyclops lesion?
So cyclops is a creature.
I'm asking Gautam this.
Sir, I don't know, sir.
Rajiv, you asked the question.
Its shape is like cyclops, sir.
What is the cyclops shaped?
It's like some कुछ organism होता है सर पानी में.
कौन सा organism?
Like crab.
Fish, like
it looks like a fish.
Yes, sir.
So
cyclops.
Yeah, Arvind.
So cyclops is a creature having one eye over the head.
So which creature is that? It's from Greek mythology, okay?
Yeah.
These are one-eyed.
Okay, sir. Okay, sir.
One-eyed monsters which were there in the mythology, Greek mythology. Just like you have various strange creatures in Ramayana and Mahabharata, etc. So even the Greek mythology had all these strange creatures there. So Cyclops is this one-eyed monster, and it's got this head that is big and sort of. So this looks a bit like that. So it's like a mushroom-shaped lesion. Yeah.
Yes, sir.
So another question in the chat box: how graft heals, sir?
So graft healing take very long time. So that's why I said the rehabilitation should be slow, particularly when you are doing the revision ACL reconstruction. So usually it starts with healing with the bone, and almost 70 to 80% get healed at the end of 6 months only. So many the experienced surgeon, orthoscopic experienced surgeon says at least a sport should be avoided for at least a year, like senior surgeon says. But the younger surgeon usually start allowing everything at the end of 6 months. So many a time that non-healing part with the bone is because of aggressive rehabilitation also. So that part has to be kept in mind all the time when you are doing the revision ACL reconstruction. Like Joshi sir always gives short knee brace for very long time, 6 weeks to 2 months for all these ACL patients. So
then would you prefer a bone patella or an allograft bone patella for, say, an athlete or a sportsman?
So literature says whether we are using this allograft or autograft, the chances of healing with autograft is little bit higher. Not much difference is there in the literature. So
what about using bone patella, bone tendon or whatever?
Yes, sir. So bone patella tendon bone graft literature says there is no difference at all. Little bit of better healing, early healing with this autograft. So in Europe or US, almost people has shifted toward this allograft of bone patella bone.
No, but would you prefer that in an athlete as opposed to a regular person, or is there any evidence of that?
So those who have been sorted,
because they will want to get back to sports pretty soon. Huh?
Yes, sir. Those who having shorter time for this injury, like want to go to a sports within 5 months or 4 months or something like that, then bone patella tendon bone graft is definitely having added advantage. At the same time, the laxity that was associated with the soft tissue graft is less with bone patellar tendon bone graft. And also the chances of revision, literature says bone patellar bone graft having less revision in comparison to soft tissue graft. But recent literature in detail says the soft tissue graft was thinner, less than 8 millimeter diameter was that, and bone patellar tendon bone graft was either 9 or 10. So if the soft tissue diameter is 9 or 10, then the chances of revision is equal with both. Only thing, the chances of infection with soft tissue graft is higher in comparison to bone patellar tendon bone graft. The reason nobody knows. So nowadays everybody used to soak the graft with vancomycin solution, and at our center we also inject intra-articular vancomycin along with tranexamic acid at the same time after closing the wound.
Sir, is it better to put it in vancomycin solution or vancomycin powder?
It's better to put in vancomycin solution so that your graft will fully soak with that.
But the diameter sometimes it gets increased, maybe theoretically, sir, or it gets swollen, or it's the same size, sir.
Graft is same. It's little bit maybe subjectively you can say it's swollen, but when you pass with this graft size, the graft remains same.
Sir, another thing I want to know, do the material of the screw also affects the longevity of the surgery, sir, or the complication like ACL failure? Material of the screw, like sometimes metal screw you use, sometimes it is bio screw, or now you are calling that bio screw is also getting obsolete day by day.
So metal screw for soft tissue graft, you have to choose very carefully. Diameter should be either same size or little bit smaller is better. If you are using bigger diameter, then their chances of cutout with the soft tissue graft is there. And also, when you are making exact anatomical tunnel on the femur, suppose only you have left 2 millimeter of the posterior wall and diameter is 9 millimeter, and you are using the 9 millimeter diameter, then chances of blowout of the posterior wall will be there. That happened with me very early time, very beginning in 2013. When I was using the metal screw for the same size femur tunnel graft that was very anatomic, only 2 mm of wall was there. So in that 9 mm of graft, soft tissue graft is already there, and you are putting the 9 mm of the metallic screw, and in that time the posterior wall get blowout. This is not a problem with this bio screw, because this is the soft screw. This get accommodated in the tunnel.
So nowadays you are using the bio screw, sir, or something else?
The bio screw for the tibia, or this suspensory fixation for the femur most of the time.
And sir, another thing which I want to ask, sometimes we are not repairing the meniscus, or even if the patient is having meniscus injury associated with the ACL tear. So if we left the meniscus as such, do it also has a effect on the longevity of the ACL, sir?
So whenever ACL injury is there, John sir from very beginning used to say isolated ACL injury is very rare. So now we all know it having very series of this the mechanism of injury in the knee that leads to ACL injury. So there is ACL injury is there, chances of meniscal injury is there, anterolateral ligament is there, and the condyle lesion is there. So you have to assess what is the significant other structure that torn. Many a time ALL is torn, but it's no significant instability associated with that. Like pivot shift is not there, even though we see on X-ray that second fracture is there. So that after ACL reconstruction or before ACL reconstruction, you have to do very good clinical examination under anesthesia and look whether associated thing or not. So this is for the collateral or anterolateral ligament. Along with the meniscus, so when you are examining the patient in OPD or under anesthesia, if too much of anterior excursion is there, like this blown grade 3 anterior dot S positive is there, or you are feeling something getting stuck and then get released. It means there is meniscal lesion is there, and nowadays there is ramp lesion. Whole of the meniscus come with your tibia anteriorly because your meniscus has separated from the capsule. So that part is also there, should be kept in mind. So whole of the tibia along with meniscus coming. So ramp lesion along with very grade 3 anterior dot S positive, you should always repair the ramp lesion also, because this is another stability point for the ACL. When there is bucket handle tear, then we should, if it is fresh, young patient, like environment of the knee is very good for healing, then we should try to preserve the meniscus. But if older patient is there, already there is some type of condyle lesion is there, like environment of knee is not very good for the healing of the meniscus, or longer duration of the time, more than 6 weeks. In that time, we can sacrifice the meniscus in form of partial meniscectomy. But whenever possible, try to repair. There are nowadays lot of very good implant is also available that is very easy to repair the meniscus. But at the end, after repairing the meniscus, we should always look for the knot, strength of the knot. It's not like just putting the implant will take care of healing of the meniscus, because healing meniscus is very difficult thing. So always your knot should be very strong, just like a skin suturing. Your skin as opposed, and it's very good. If you are opposed the meniscus in with very strong knot, the chances of healing will be very high. So what we are doing at our center, we are putting the circumferential stitch with the help of mini scorpion is there, or meniscal cinch is there. With that we are putting the circumferential stitch around the meniscus, and that knot is a strongest knot. So that help in better healing of the meniscus.
So another thing, sir, during the primary ACL reconstruction, if the graft what we are using to take hamstring graft, if it is
I think Janaki's connection is
Connection is
good. So I think any other questions from the DNB students? Otherwise, we'll call it a day.
Sir, is there any artificial material available, or how successful is that?
So you just talked about some.
Yeah. So particularly for the ACL fiber tape, people are using when there is fresh ACL injury. They are repairing it ACL, at the same time augmenting with the fiber tape also. And many a time those athlete needs, there is no time for rehabilitation or rest. In Europe, people are also just putting the fiber tape in place of ligaments, graft, and allowing for the sports. And after completion of sports, they get operated with ACL reconstruction. So fiber tape, we are also did almost around 7-8 cases of ACL repair with fiber tape augmentation.
There's also something called the last ligament or something like that.
The last ligament came, and again they lost market because there was lot of synovitis
tissue reaction.
The soft tissue reaction was, and that tunnel dilatation was like anything in this type. The longest study is with this fiber tape. They initially started with the collateral almost 10-15 years earlier, and now intra-articular fiber tape augmentation for last 10 years.
Yeah, so they use a lot for, it's used often as augmentation rather than the only structure.
Yes, sir. Mostly for the augmentation.
Okay, I think.
Yeah, one question about that. If it is infection, sir, in revision, should it be a one-stage surgery or two-stage surgery?
It should always be two-stage surgery.
In for ACL, something like ACL, I think you need to get rid of the infection before doing anything. Otherwise, you'll be in trouble.
So, think just one more question about the if it is mild varus deformity associated with the primary ACL tear, do you use something for varus deformity also?
If there is significant varus is there and there is medial meniscus loss is there and other thing is there, then you can go for osteotomy. But if varus, mild varus, both the sides it is there and meniscus is normal, then you can escape the osteotomy part.
Or if they have very early medial compartment osteoarthritis, with varus, with significant varus, that's maybe a situation where you think of it.
So, in any case, sir, during the revision of ACL, you think that the replacement may be an option for that TKR instead of?
Yes, so when there is arthritis component is there, meniscus is completely lost, there is varus, then definitely this.
And also the age of the patient. Now, if he's 65 or 70, then you're not going to do revision reconstructions because usually by that time they'll also have arthritic changes and maybe better to do a TKR. But in younger patients, you don't have that option.
And sir, you mentioned about that rehabilitation protocol, if it is not taken properly, may be a cause of failure. So, what is your advice for the rehabilitation, sir? What all the patient should do?
So, every knee is different. You should plan your rehabilitation according to the knee. Many a time it's isolated ACL injury, so rehabilitation may be fast. When it is associated with some type of collateral ligament, you plan to manage conservatively only. So that type of rehabilitation should be slow, and assessment should be frequent. Initial 2 weeks, then again after 3 weeks, then again after 3 weeks, and look for how your ligament is going on. Look whether there is laxity of ligament is excessive or not. If it is excessive, then you should be very slow. So this frequent examination of the knee also. At the same time, what are the other structure associated with the ACL? That has to be also considered at the same time. So it should not be generalized for all the patients.
And also you have to develop your own protocols. I mean, you can't just give one thing for everybody. Yeah? So it's not as if...
So just one question, what patient used to ask during the immediate
one question for Anki, you said one question at least 10 times. Huh? So either you say 10 questions or you say one question and stop after that. Which one is it?
Sorry, sir. Actually, sir, what the
one more question or you have 10 more questions? First decide. One more question. Okay, let's go.
During the early post-operative period, patient used to ask that he can remove the brace in the night or not.
For initial 2 to 3 weeks, the brace should be there in the night. That will prevent the more than 90 degree of active flexion.
So that is for initial 2 to 3 weeks, sir.
Yeah, 3 weeks, for at least minimum 3 weeks.
Okay, thank you, Arvind. That was very useful, and I think we should call it a day because it's already.
Thank you, sir. Thank you very much.
So till next week, what have you got planned for next week, Janki?
One thing, just we will just discuss it because one growth.
Okay, fine. We'll go. Sure. Your volume has gone. Okay, so.
Oh, sorry.
Okay, then. See you next week. Bye.
Thank you.
Thank you, sir.
हाँ सर खत्म अभी हो गया है, क्या आप बता रहे थे इंड करना है? रिकॉर्डिंग एक मिनट सर। हाँ हाँ हाँ, नीचे दिख, स्टॉप रिकॉर्डिंग, रिज्यूम हो गया, नहीं रिकॉर्डिंग पॉज्ड हो गया। हाँ सर रुकिए, स्टॉप कर, एक मिनट सर। स्क्वायर दोनों तो, अच्छा स्क्वायर वाला तो वाला है। डू यू वांट टू स्टॉप क्लाउड रिकॉर्डिंग? यस यस सर।